Hello, everyone, and welcome. I am Sally Davies, an editor at Aeon magazine, and it is my pleasure to welcome you to today's discussion on the profound effects of the paradigm shift that's currently underway in the US on science, public health, and global health policy. So, some very quick housekeeping before we begin. We plan to discuss the topic for about an hour. So in the first two-thirds, we'll hear from our panelists in conversation with me, and during the remaining time, we'll open the floor for questions. That said, please do feel free to drop questions as they occur to you in the Q&A, and we'll pick them up organically as the discussion proceeds. I do just want to acknowledge at the outset that today's topic is particularly sensitive and also rapidly evolving. And many people in the scientific bioethics and healthcare community in the US and beyond are experiencing profound moral distress, professional uncertainty, as well as grief and suffering, along with the many affected vulnerable populations. So I would just ask everyone, both panelists and participants, to proceed with compassion for one another as the discussion unfolds. So to begin with some contextualizing remarks, since the start of this year, the world has stood by aghast as the Trump administration has transformed US health policy and scientific governance. Within days of Trump taking office, the administration issued executive orders withdrawing the US from the World Health Organization, freezing international aid, beginning to dismantle USAID, reinstating conservative positions on global and reproductive health policy. Domestically, the changes have been equally dramatic. On the 1st of April alone, approximately 10,000 federal health scientists and officials were summarily dismissed, many learning that they were fired only when security guards prevented them from entering their workplaces. At the CDC, entire divisions have been eliminated, including those tracking violence and antibiotic resistance. The administration has declared that there are only two genders, quote unquote, as official government policy, reversing protections for transgender individuals and prohibiting gender-affirming care in federal settings. Meanwhile, Immigration Customs Enforcement has ended the protected status of hospitals for undocumented immigrants, creating a chilling effect whereby people will avoid seeking medical care out of fear of deportation. A particularly troubling development in all of this, and particularly relevant for those of us in attendance today, has been the emergence of both direct censorship and self-censorship within scientific and ethical communities. Federal scientists report being barred from publishing certain research findings without executive branch approval. Some have been advised to withdraw their names from academic journal articles, and many institutions and organizations have remained notably silent, perhaps out of concern for funding, political backlash, or institutional survival. These changes raise profound questions that go beyond politics to fundamental ethical principles, including the four principles of bioethics being autonomy, beneficence, non-maleficence, and justice. In particular, as one of our panelists said to me earlier, this represents a real moment of reckoning for bioethicists who take the principle of justice seriously. So just what duties do health ethicists and academics have to act at this historical juncture when evidence-based policy and health justice are systematically undermined? Most urgently, what can and should be done right now? So whilst much about the present moment can seem bleak, I'm confident that nonetheless our panelists will be able to shine something of a light in the dark, at least I hope so. So I'll now just ask each of them to introduce themselves and offer a few brief comments, if they would, as to their orientation on the subject of the panel. Lisa, you're first in line, so I'll call on you first.
Sure. Thank you so much, Sally. And thanks to my colleagues for joining this, and Roche for hosting it with the Independent Research Group for Global Health Justice, of which Sridhar and I are members, Sridhar being the founder. So I'm Lisa Eckenwiler, professor of philosophy at George Mason University, just outside DC. I started off in a very traditional line of work in bioethics, looking at research ethics and access to care for HIV patients. But ultimately, I have evolved more into the direction of global health, or moved more into the direction of global health, I'll say, and work more on issues around humanitarian health ethics and migration and health ethics. I was the vice president of the International Association of Bioethics for a time, and have held some leadership positions in the American Society for Bioethics and Humanities as well.
Thank you.
And I guess in terms of my orientation, I want to talk about what the implications are for health ethics as a field of what's been happening in recent weeks.
Thank you so much, Lisa. Greg, I'll call on you next, if I may.
Hi, everybody, and thanks to the Foundation for bringing us all together. My name is Gregg Gonsalves. I'm an associate professor of epidemiology at the Yale School of Public Health, and an adjunct associate professor at the Yale Law School. And I do, in my day job, work on HIV and substance use issues, um, but think more broadly about the issues of health justice in my work between the law school and the public health school. My orientation is this. I am a scientist, a working scientist with NIH grants at the current moment, and feel acutely what is happening to me and my colleagues in terms of the sort of practical day-to-day impacts of it, but the ethical impacts of it as well. And we can talk about that more broadly. The other piece of this is that my larger background is in social movements, starting with ACT UP, Treatment Action Campaign in South Africa and other places. And what is happening has profound ethical consequences for many of my colleagues and comrades around the world, which I think we need to talk about as well.
Thank you so much, Greg. I'm looking forward to unpacking some of that. Sridhar, over to you.
Hi, everyone. So, as Lisa said, I want to first thank Brochet and the other fellow panelists and Sally and all of you for attending today. My name is Sridhar Venkatapuram. I'm an academic mostly. I call myself an academic practitioner because I try to do things in the world at the same time. I work at King's College London in global health and philosophy. My background is that, like Greg, I also started in sort of AIDS activism, but I also worked at Human Rights Watch. And basically, what got my interest in philosophy is when the head of Human Rights Watch said that there's no such thing as a human right to health. And so the idea was, how do we make something convincing and how do we make an argument for a human right to health? And so I'm interested in a present moment. One, I think that I won't speak for Greg, but I'm used to social crises and going against the grain and sort of trying to say things that people don't want to hear or are afraid to say. And I think that it's that kind of moment where we really need to think about what are the ideas and concepts that require articulating or advocating in a time when people's lives are at stake in the millions. And two, I think that there is a lot of work for ethicists and bioethicists of all kinds and public health ethicists. And that's why I use the word health ethics more than bioethics. And so I'd like to talk a lot today about all the work that is currently needs to be done from an ethical perspective. Thanks.
Thank you so much for laying that groundwork. Soji, over to you.
Yes, good morning and thanks for having me. My name is Soji Adeyi. Calling in from Washington, D.C., where I lead Resident Health Systems, which is a small policy analysis and consulting firm. And I'm also on the faculty at the Johns Hopkins Bloomberg School of Public Health up in Baltimore. Today, I speak in my personal capacity. And I'm going to come at this from a dual perspective. The first one is, what does the current moment, what does it reveal about the construct that we call global health? And building on from that, what does it mean for the future of the construct that we call global health? We can wrap that up in the rubric of social justice or health ethics. I'm going to delve right into the political dynamics of it, quite a bit of which might go against received wisdom, but so be it. So looking forward to an interesting discussion. Back to you.
Thank you so much. There's a huge amount to cover. I'm going to apologize in advance if we don't get to it all. And I would also want to invite our panelists, if they feel particularly strongly about something, to sort of steer the conversation in that direction. I think I'm trained as a historian, so I have a bias towards de-exceptionalizing the present moment to some extent, or at least always looking to historical analogies. And Greg and Sridhar, since you've both had extensive experience with ACT UP and HIV/AIDS activism, I'm curious if you could share with the panel some of the lessons that you've learned from that particular moment of social crisis and moral challenge. What should practitioners and theorists and academics take away from that experience in terms of helping them understand how to act now?
Greg, since you're the senior member of the two.
Oh, that means I'm an old person. A couple of things. I've been thinking about this quite a lot lately, and you know, the beginning of the AIDS epidemic, a film historian named Vito Russo wrote a piece about why we fight, and it talked about how societies that are not impacted by concentrated epidemics sort of experience it as they don't know what's happening to the gay community, the sex worker community, the community of people who use drugs. And during the 80s and 90s, it was an existential crisis for us, but it was not an existential crisis for many of the people in the city that I lived in, New York City. So if you fast forward to 2000, my colleagues at the Treatment Action Campaign and around the world were experiencing this in the context of generalized epidemics in places like South Africa, which has the largest AIDS epidemic in the world. Fast forward to COVID-19, when the entire world is now implicated in a crisis which is deeply existential for millions and millions of people whose lives have been lost, who are now suffering from long COVID, and the like. And so, I feel like I've been part of three existential moments for my communities. And now we end up with one which has the potential to be as devastating domestically in the US as any virus, and has the potential for ramifications around the world, which will make COVID-19 look like a picnic.
Thanks, Ellie. I think that that's a fantastic way that you said is to not make this into an exception and sort of look at it from the past. As like Greg, I've also been thinking about this. So one thing is that I think it's very uncomfortable for many people to be against their government. And this is one of the things that I think is very, sort of unusual for a lot of people about the situation, is that they've never been, they might be against a political party or sort of a short-term thing, but this is so significant that to be sort of, say, systematically against the structures. I think during the AIDS activism period, we were very clearly very comfortable with this idea that government institutions are insensitive and negligent of certain populations of people and death and disease. That's something that we lived with every day and we were fighting against. And that's something that we became sort of aware of and worked with. It's not that everybody that was doing HIV/AIDS work was sort of an activist. There were some people who were not activists, and there were lots of people that were, vulnerable to HIV in a variety of ways that didn't become activists, that sort of simply tried to figure out how to live their lives and go on as well. So don't, I don't want to make everyone into an activist. They're not going to be, and they're not going to do that kind of work. But that fundamental notion that being in a space in which your government doesn't care or is negligent or violative is very uncomfortable. It's something that needs to be that you need to be able to be comfortable with. The second thing is that, this idea of social norms, right? So when we were doing HIV/AIDS work, you were considered to be a really kind of weird and socially ostracized person. Lots of my relatives were like, why are you working on this dirty topic? Why don't you do something else that's sort of more successful oriented and, sort of that kind of orientation. So this idea of doing work and addressing issues that socially don't feel acceptable is something that also needs to be something that people develop in order to sort of deal with the current situation. And the third thing is to be able to live with disappointment, in the sense that in that period of time, in the early years, bioethicists were not interested in HIV/AIDS. They didn't think that it was an ethical issue. It didn't sort of really ring the bells for a very long time. So the first 2-3 decades were sort of bioethics didn't really think about infectious disease and what are those kinds of issues. So it's okay to also sort of understand that your colleagues are not going to be interested in this kind of sort of work that we are talking about today, that they want to just keep doing the work that they want to do. So those are the three, I would say, lessons from HIV work that I would bring forward to people sort of saying, what do I do now with this current crises? Thanks.
That's really precise and I think quite interesting in that I mean, a common thread that runs through each of those lessons, I think, is a willingness to tolerate a new form of discomfort. And I wonder if, in terms of, I mean, a question I wanted to ask the panel was sort of about, you know, the individual ethical responsibility of practitioners or scholars in this moment. And are there different models for what that moral responsibility could look like? Is it ethically defensible for some people to be radicals and others to be pragmatists? And how should one individual person sort of make that assessment for themselves about what's reasonable? Or does the panel think that, in fact, this is a really crystalline moment where a kind of single model of resistance is called for and we all need to rally behind it? I'm curious for the panel's views about, I guess the question I'm asking is kind of different models for pushback that people, you know, practitioners and scholars could look to in terms of helping them understand how to act.
Lisa, go for it.
Yeah, well, I mean, I want to come at this, you know, maybe in some different ways later, but I think that one of the things, what I guess I really like to speak to is not what the responsibility of individuals is in this time. What I want to really focus on is what our responsibility ought to be as a field. I think, you know, part of what we've seen right now is an excessive reliance, a deference to individuals sort of carrying the banner and being the ones to speak out. And I think we shouldn't rely on that, because I think that's the sort of thing that makes people vulnerable, right? And differentially so. If we were thinking about HIV, there were people who were, you know, harassed for speaking out, you know, as the panelists have spoken out. So I think we have to think about, you know, what are the conditions at play and what levels of risk are people in different situations willing to tolerate. I'll just say one thing parenthetically before I move on to the point about the collective. Like, the Australians have, I think, some things to teach us here, for example, about what health professionals had to do in the context of migrant detention, right? So some people were, you know, saying that they didn't want to get involved in the political debate. They just wanted to go attend to their patients and perhaps observe, at most witness. Other people took the position that they were going to speak out against the government, you know, even at their own peril. Other people took the position that they were going to do things that we were going to manipulate government policy in certain ways, like not return kids to the detention facilities, going against what they've been ordered to do. So I think, and this leads me to my point, I think the thing that we need to think much more deeply about as a community is really trying to envision ourselves as a collective. I think we've devolved to the point, at least since when I started my work in the field, to just being individuals who at most participate in interest groups. And I think that there is a lot that we could learn from one another across countries. So, for example, what can we learn from our colleagues in Ghana about efforts for governments to censor universities? So, you know, our friend Cesar Atwiri has a lot to teach us, for instance, about how Ghanaian universities banded together rather than acting individually and resisted those efforts at government censorship. I think we could act more as a collective if we think about what the Australians have to teach us about, again, how we respond to conditions in migrant detention, or how we respond to a situation when hospitals are no longer protected places. So I think it isn't a matter of, you know, individuals are in their positions as doctors, nurses, scientists, people working at the CDC, and they, in occupying those different positions, play a really important role, I think, in helping us all understand what's happening in those specific locations. So I think if there is a minimum responsibility, it's sharing information. Speaking out, I think we can have a conversation about. But I think that those individuals who are differently positioned, whether they're differently positioned in jobs, differently positioned in terms of leadership positions, or differently positioned in different places in the world with different kinds of background conditions, we all need to think about ourselves as a collective and act together in ways that allow, I think, us to exercise more power, and stand together against things that are clearly wrong wherever they occur, whether that's, bombings of hospitals, killings of health workers. We should all stand against that, not as individuals solely, but as a group.
Lisa, can I
Part of what I really
follow-
want to talk about eventually is the commitment to neutrality that I think is part of what inhibits us. But I think the other thing that inhibits us from taking action is this sense that, or a lack of sense that we're a collective as a field.
I just wanted to push you on that, Lisa, because I think it's really interesting. Are you you seem to be calling for some kind of collective action on behalf of bioethics as a field. What's your theory of change around that? Is this a kind of ACT UP style organization? Is this an institution like leading the charge? What's your sort of proposal for how to overcome the collective action problem in the context of what's happening at the moment with US health policy?
Well, I think we need to revisit the conversation within our professional organizations about whether it's acceptable to take positions on substantive policy issues. So it's not that I want to say what the theory of change is. I think that it's time, though, to reopen that conversation. And I think it's time to learn from organizations who've made the decision that they are going to take positions and speak out against clear violations of ethics, actions for which there is no credible justification, bombings of hospitals, for example, right? So I think that we need to learn from the organizations that have been through these debates and hear how they process them. Like, how did they reach the point where they decided that they were going to jettison their commitment to neutrality? And how did they process their coming to create a position statement? Do they allow for dissent? Do they, I think that what I'm not calling, let me be clear, what I'm not calling for is unity among bioethicists or people who work in health ethics. I'm not calling for agreement on particular issues. Rather, I think what we should be thinking about are, what is the floor, things that we all can stand against. And then as a community around the world, we talk about how we've come as organizations to process our views, to create statements that acknowledge the dissent, that acknowledge the disagreement, but that doesn't leave us silent in the face of brazen violations of the values that we work to defend and stand for in our teaching and in our research. If we don't stand up for those things, it's not clear who ought to.
So does the panel agree with Lisa's assessment? Is this a good first step? Is that what should be the sort of beachhead struggle for bioethics and health ethics as a discipline?
Let me jump in here, speaking as somebody who is not an ethicist, which means I come at this with 100% open mind. You might also call that utter ignorance, depending on your preference. We heard about the individual and the collective, etc. Let me cast it differently. And here I'm going to channel Reinhold Niebuhr, who wrote in Moral Man and Immoral Society that perhaps the most significant moral characteristic of a nation is its hypocrisy. So I'm going to channel that and pivot to global health, that perhaps the most significant moral characteristic of global health is its hypocrisy. How so? Implicit in the uproar that followed policies announced by the US government in January and February implicit in that uproar is a sense that life before January 2025 was just fine. Now, ponder that for a second. And that's just wrong. Now, I've been struck by the fact that, and let's back up a moment, the abrupt nature of those policies is to be decried. The fact that so many people lost their jobs suddenly is not anything to be proud of, okay? Or that many folks who are suddenly at risk of losing services, essential health services in those countries that were benefiting from programs financed through or by USAID and PEPFAR, et cetera, et cetera. That is nothing to be proud of. It's wrong, okay? Certain things are equally true at the same time. Implicit in that uproar is an endorsement of what came before it. But what was happening before was pretty bad. So let's be candid and let's unpack it. The global health construct that existed before January 2025 was predicated on this idea that you construct a burden of disease and you find the most cost-effective interventions and you develop packages of essential health services, and then foreign aid donors will pay for those essential health services. I'm oversimplifying a little, i.e. they were purchasing the best buys. It seems to make sense at the first glance, but then you ask yourself, does that make sense? Why should external parties be paying for the most cost-effective interventions for the most highly prevalent basic needs in low or lower middle income countries? Now, 25 years ago, AIDS was a monster emergency. Today, AIDS is still a big, big public health problem. But one could argue that it's no longer the emergency that it was 25 years ago. So why is it that countries who are the beneficiaries of those of the foreign aid largesse had not substantially taken over responsibility for self-financing? Well, it's because there was a lot of rent-seeking in the donor countries, including United States, and a lot of rent-seeking in the recipient countries. If you look at the construct called the quality of aid that was developed by the Center for Global Development, quality of official development assistance, about 3-4 years ago, US foreign assistance ranked around 35th or so on the list in terms of its quality relative to what was most relevant to the countries. So if you were a US taxpayer, your money was being sent down the drain substantially before this year. But the foreign aid industrial complex had cornered the market. That's one. So let's now lay it down. Before all of this erupted, one posited that there was something terribly wrong in the whole charity approach to global health. And let's be honest about it, a lot of the uproar is, let's keep sustaining this charity. And I identified 4 pathologies in what are called a misguided charity in global health. The first one was this insular presumption of superior wisdom, mostly in the global north. And the exemplar of that is in Seattle. I mean, just because you're a multi-billionaire does not mean you know everything about everything in global health. But you have this pronouncement that if I like this antigen or if I like this technology, then it should be adopted by Gavi, and then you should start paying for it. Or if I don't like sharing intellectual property, then a vaccine developed at Oxford University should not be available to everybody unless they adhere to some intellectual property protocol. A second pathology is what I call abdication of the duty of care, which was there aplenty during the COVID crisis. So I'm at the height of the COVID-19 pandemic. I'm not going to go into details of that. A third one was the tendency in global health circles for folks to pontificate outside the circle of competence. And there's something unethical about that too. Although you might argue that that is not necessarily a global phenomenon. I mean, if you have a health minister or health secretary, such as you now have in Washington, D.C., who routinely pontificates outside the circle of competence, well, maybe you get a sense of what has been pervasive in global health. Okay, and then finally is this irrational escalation of commitment. Folks embark on something that is patently nonsensical, such as what's going on at USAID with regard to their supply chain contract. And despite publicly available information about the shortcomings of that approach, they were going to double down or triple down and pour taxpayers' money on that. So if you're a US taxpayer, that is how your money was being spent before January 2025. Now, I'm not justifying the government decisions of January 2025. No, not at all. Not at all. But the flip side of it is the following. There's a dangerous narrative that is coming out of the US and many global North countries. The narrative of the indispensability of foreign aid to the global South countries. I think that narrative is unethical, it is shameful, and it should stop. Now, many people are likely to experience service disruption as a result of this abrupt change in policy. So the problem per se might not be the change in policy per se. It just might be the abrupt nature of it. That it might have been eminently sensible to say, these programs are going to be phased out over 5 years or 6 years or 7 years, whatever the period is. Allowing them to wind down rationally and for the countries to explicitly take on more responsibility. Apart from, of course, countries at war or experiencing terrible natural disasters and the like. So a plea, do not keep infantilizing the countries and do not keep positioning donors of foreign aid as indispensable. I will rest this for now, but I'll have quite a bit more to say later. Back to you.
Soji, thank you so much. That is a really necessary and interesting intervention. I mean, can I just reflect back at you to distill to some extent what I've heard, which is, do you think that this moment of crisis as it's perceived, that in fact there is perhaps a silver lining to it in breaking what you've described elsewhere as kind of neo-dependency in global health? And could this paradigm shift actually lead to more locally driven health initiatives in low and middle income countries, which would work to everyone's benefit?
The short answer is absolutely yes. Now, let's be clear, as I've written elsewhere. I think the inequalities, the North-South inequalities, the repercussions of colonialism, they're real, they're terrible, and they endure. But in my mind, the more fundamental problem is dependency, is not neocolonialism, is neo-dependency. And it manifests in several ways. I was sharing with some British colleagues some time ago that when the British have these spirited debates and discussions about their NHS, and some of those debates can be very nasty sometimes, that's okay, because the continued legitimacy of their health system derives from those internal debates that the British have. But when self-styled do-gooders from Europe and North America, usually, make up policies and then want to go and execute those in Nepal and Sierra Leone and Nicaragua, they're unwittingly denying those people the opportunity of having those messy debates in their own countries. And that is just flat wrong. So one of the most useful things, in my view, that the global North can do is something that they're very, very unused to doing, which is, for goodness sake, just back up a bit. Or to put it bluntly, back up and shut up for a while. and let the countries figure things out for themselves. I think that's one of the most useful things they can do. It also means it puts pressure on the government of those countries because they no longer will be able to blame the imperialists for all that is going on in their own countries. They become more accountable to their own citizens than they are to Brussels and New York and Washington and Seattle. Back to you.
Sridhar, you wanted to jump in there. I wondered if this was a moment you mentioned that, you were keen to talk about certain truths or concepts that people were afraid to say. I mean, I certainly think Soji's analysis probably falls into that category for many people. Was there anything you wanted to share in response?
Yeah, I mean, I think that Soji's courageous argument, and I've been a fan for his now few years now, is really important. The thing that I would like to add is that very recently in the defense of USAID, you will see that the number one reason is usually for self-interest, right? So for decades now, we've been told that USAID is all about helping other countries and development and saving people's lives. But now what you realize is actually USAID had a very clear national self-interest as its main goal. You weren't able to say that out loud before. And now people, when they have to defend it, use that as the first primary argument. So I think that that's an important thing for everybody to understand. The second thing about cost effectiveness within a country, as Soji has pointed out, is that this doesn't make sense. But what you see is that the countries that get USAID is not where you can get the biggest bang for your buck in the world. It's where the national interest is going to be sort of most successful. And so it's not about promoting the greatest health in the world. It's in those countries that will sort of do or need to sort of be allied with us. What can we do in terms of the greatest efficiency? The third thing I think is that while the self-reliance argument is profoundly important, the real politics of the global stage right now are that as US withdraws, other countries move in, and the political leaders of those countries will take the easy way out, which is, well, if it's not US dollar, it might be some other currency that they will use in order to replace that. That's a real problem where you sort of replace one dependency with another one because it's the easy way to go because the money keeps kind of coming in and you might be able to justify that in some way. But you don't get rid of the dependency problem just by sort of telling the Americans to back off. You also have to convince sort of countries that are quite desperate for funds to be able to say, well, you have to figure out other ways to do it. Then no. The third thing that I want to say is that I think Soji's argument itself says you need at least 8 years, if I remember, of lead time for a sudden stopping of foreign aid. We have literally got no sort of period. So what's happening right now is that millions of people are suddenly, their medications have stopped, their healthcare has stopped. So people are dying. And this is where I think one of the places where health ethicists should be providing some assistance, and they're not, as far as I understand, is that as people have to make difficult choices about how are we going to deal with who gets the limited medications that we have and who's not going to be able to do it, how do we help people figure out other ways to live or die without these medications, and what are the different kinds of stuff? That's work. That's not technical and scientific. That's ethics stuff. And we should be on the front lines of that. There's also a similar kind of thing happening in the US that we can also talk about. But I just wanted to add to Soji's argument, like supporting that, but also expanding sort of other parts of that argument as well. I hope that aligns, Soji, and I'm happy to be disagreed with.
Thank you so much, Sridhar. Gregg and Lisa, I'm conscious you both wanted to jump in there.
So I agree with everything Soji said, but I think we also have to talk about the sort of transnational nature of extractive and exploitative elites, and that it's not just about need or dependency. It's about exploitation and extractiveness that's happening at local levels, right? That you could stop foreign aid today, or you could do it in 8 years, but it doesn't change the ground truth in not all countries, but many countries, which are not necessarily going to do the best by their own people, right? The second bit of this is that Trump is building a permission structure and incentive structure to do more of this, right? exploitation, extractiveness, transactionalism is on the rise, right? This is the sort of rules of the game now, right? And who's going to stand up for transparency, good governance, equity in the context of sort of this global moment? And I think that's what's at stake. The conversations we're having for the past 15 minutes, we could have been having before, as Soji said, in December 2024 or December 2023. What is it, does this moment present anything? You wanted to talk about this in a historical perspective, but is there an exceptional historical moment happening now that takes us out of sort of the longer arc of what's going on? Or is the threat just more of the same and it's really only, April 2024 all over again?
Lisa, I'll bring you in there and I'll just throw out to the panel. I mean, a question I think that's emerged from this recent conversation following Soji's intervention is the extent to which there are genuinely alternative models of global health governance that could emerge from this moment, as opposed to a continuation of dependency structures in a different form, a continuation of logics of extraction. What are the ways by which those alternative structures could come into being, given we are in the situation we're in? But Lisa, I'm not sure if that's where you wanted to go. I'll bring you in at this point.
There's so much, and I can't believe how fast the clock ticks in these things. There's a lot I wanted to say, but let me just circle back to the point about history and what we ought to be doing at this time. Whether you want to point to the Hippocratic Oath or the Nazis, or maybe in the U.S. it's Tuskegee. There are different origin stories for bioethics. I think we could probably all agree that it's the Nazis. At least that's our international connection. So what was the center of the field? What has been our raison d'etre? It has been, at least this is what I thought we were doing and what I teach my students, that we serve as watchdogs, that we serve as ethical resources. Pick your favorite metaphor. We are architects of moral space. We are framers of ethical questions and of alternate moral pathways, navigators through moral pluralism. We are the people who have been making the critiques of global health. We're the people who've been making the critiques of public health, the critiques of clinical medicine, and we've been the people who have been trying to show the way forward. Isn't that the thing that gets most of us in the field out of bed in the morning? This isn't good enough. We should do better. So the fact that we have seen lesser violations of human dignity and justice than we are seeing now, lesser threats to all of the ideals that we stand for, and yet now seem paralyzed in, again, our collective silence. Individuals are writing, individuals are speaking out. But that is not how we identified ourselves ultimately, which was as a movement of watchdogs, a movement of architects of moral space who insist on certain ways of treating people, and I would add other forms of life. I think we should be the leaders who are calling out and calling on public health leadership, certainly in the US, but elsewhere, but certainly now, to ask them to articulate what is the ethical underpinning of policy actions. We should be asking, what's the ethical underpinning of decisions that were made about USAID? We should be asking, what's the ethical underpinning of the way that we're treating migrants and others, transgender people, the kinds of things that we're saying about autism. We should be calling that out, and we should be showing the way for the better future. But I don't think we do that as individuals effectively. I think we have to do that in an organized way within our countries, but also across borders. And I think this is the moment for bioethics to mature into its next manifestation.
I think, Sridhar, you wanted to jump in there, but I guess in response to that, Lisa, I'd say, I think it's what I think is emerging from this conversation is this idea that if we are to use this crisis, although, you know, based on Soji's comments, we might want to question that, in a generative way, the only way that that collective action can take place in a form that's truly just is if the objective isn't to return to some sort of, you know, halcyon days, golden era past. It actually requires a holistic assessment, a holistic reassessment of what global health justice looks like. And there is perhaps, what I hear in Soji's intervention is a fear that, you know, the outrage is really only kind of on behalf of, you know, the global north kind of looking at itself and in fear. And actually a lot of the wrongs were already being committed prior to, you know, this seeming crisis as it was initiated in January. Gregg, you want to jump in there?
So we can do two things at once, right? I don't understand. Soji's critique is absolutely essential, right? But pushing back at the current moment and saying there are people in clinics in South Africa who can't get their HIV medications, who are going to develop viral resistance and die of AIDS within the next few months, is worthy of our attention as well. And Lisa, I don't think it's time to ask questions about the ethical underpinnings of what's happening. I think it's pretty clear that it's time for not sort of an analytics of this, but an action of this, right? Like, I've been working with lots of different people over the past few months who would agree with Soji on many of the principles we've talked about what the future should look like. But bioethicists have not sort of been around. Maybe it's in their own journals, maybe it's in their own communities, but, you know, I don't know, sort of bioethicists, this is their moment. They're stopping clinical trials in mid-clinical trial. People are being thrown off of studies. Move it up to the layer of public health and the decimation of the CDC. A whole host of other issues you can opine on and describe in the context of a bioethical framework, not asking questions about, dear President Trump, like, what were you thinking in the sort of ethical realm as you devise these policies? Because we know darn well exactly where he was coming from.
I did say call out and call on. So, amen.
I think the notion that you're talking to, Gregg, is it's possible to operate on two different speeds, right? We can respond to the needs of the present moment, but we also need to keep an eye on that longer term future of an alternative model of global health governance that Soji would be encouraging us to start to build. Sridhar, I'm conscious that you wanted to come in here, but perhaps the conversation has moved on.
Yeah, no, I think it's the same in line, and I want to give people the opportunity to ask questions or for us to address questions. I don't want to take away from that. I think you know, just adding and supporting what's going on is that there's a lot of ethics work to be done right now as clinical trials are stopped, as healthcare is stopped, as different programs are stopped, as we sort of do make lots of different kinds of decisions. But care ethics is not just about how do we, you know, ration healthcare or what do we do about that. It's also about making arguments about what the right thing to do is and what should be, et cetera. So this is an incredible moment for us to rethink it. So it's not just about global health ethics and governance. It's about US health ethics and governance that also can be profoundly relooked at. So there is no going backwards, but one of the fundamental things that is a shift from, you know, sort of history or whatever you might say is that notion of American universalism, that if we think about something in bioethics terms, it applies everywhere in the world, is just simply not plausible anymore. And so you have to really think more about, when you make an argument, is this for the American context? And is, you know, what, you know, and somebody else somewhere else in the world is going to be like, that's fine, that's your context. And so I think that that's something that's really different, is that we are seeing a kind of American you know, parochialism becoming more acknowledged and sort of in the world. And that's going to make a big difference, because you know, the way that people think and sort of receive American ethicists and bioethicists talking about stuff has fundamentally shifted, precisely not just because of the last 3 months, but for the last 3 years, last 5 years, last 10 years. And so this is just a rapid change in the status of America in that intellectual space that is quite significant. So sorry to say that, and please, yeah, go ahead.
Not at all. And look, I'm going to allow us to run slightly past the hour because I'm conscious that it's been a very rich discussion, and there are some questions from the audience. I'm just going to end this segment by asking Soji a question, which is, in light of your comments and the very interesting discussion that's ensued, how do you think other countries and international organizations should respond to the change, the US withdrawal, the parochialism that Sridhar has described? Oh, I think you're muted, Soji.
Thanks. I think in fashioning their responses, it's important to reflect on the question that is the uproar really about its fundamental end effect, or is it because this recent change in policy affects the gatekeepers, the self-designated gatekeepers? And I will posit that perhaps it's 1/3 because of its ultimate end effects, and 2/3, if not more, because its devastating effects on the gatekeepers. Okay, I will posit that. Now, as to how they might address it, I think it's important to, at least in global health, to massively reduce the power of the global level and significantly increase the emphasis on what goes on at the country and sub-regional levels. You could think of it as a principle of subsidiarity. There are too many things that are being done or attempted to be done at the global level that had no business being there because the countries could do it by themselves, or aggregations at the sub-regional level could do it. However, one of the primary functions of the global construct was to provide an avenue whereby a few powerful entities could wield disproportionate power over the entire world. So they captured those global health institutions, either for historical affinity reasons or because they bring hundreds of millions of dollars today. And I think that's probably one of the reasons why there was also a lot of weeping, wailing, and gnashing of teeth over what's happened. One last point, a reflection. I don't recall whether it was Sridhar or Gregg who mentioned this, because I think it's an important point. That is there a risk that as countries, some low and middle income countries, lose the funds that used to come from the US and perhaps European donors, that they will turn elsewhere and those terms might not be as favorable to them? You know, yeah, but I will submit that is their choice. And they have the right to make those choices. Otherwise, implicit in encouraging them not to make those choices is an idea that, quote unquote, we know what is best for them. And I think that's part of the infantilizing the countries that we need to end. I want to close by recalling a statement made by Nelson Mandela back in 1990, I believe, in a televised interview with Ted Koppel with an audience. And Ted Koppel was pressing Mandela on some country leaders with whom the ANC had associated. And if I remember correctly, Nelson Mandela started his response with an unforgettable line. He said, the problem here is that some analysts in some countries believe that their enemies must be our enemies. So if the people of Nepal, Bangladesh, Kenya, Sierra Leone, and El Salvador, if they want to do business with those other people, that is their prerogative. It is not for us to dictate to them the entities with which they should associate. Back to you.
Thank you. This is absolutely fascinating. I'm going to take this moment to bring in some of the questions from our audience. I'm going to actually combine a couple of questions here. There's been a question about the meaning of neutrality in this context. Let's take it back to, I think, the domestic space and individual responsibilities in this context. So Lisa, you mentioned that you wanted to unpack this question of neutrality more, so I think this is an opportunity to do so. And in that context, I have a very interesting question from Samir Hurst, who's a member of the scientific committee at Brochet. And she writes that How afraid are US ethicists about speaking out concretely? How would you assess the risk involved in doing so, both in terms of the likelihood that bad things would happen to you and in terms of the gravity of what might happen? And if you assess the risk at present, what can colleagues in other countries do to support US bioethicists and scholars at this time? Lisa, I feel like this might be one for you.
Yeah, well, I am poorly suited to comment on what people are feeling in terms of their level of risk, right? People in the bioethics community. So I would very much like to hear more about that. I would gather that it's highly differentiated. As a matter of fact, one of the points I wanted to make earlier, I think part of the problem that we suffer from, at least in American bioethics, is that, and I don't want to offend anybody, I hope this is just self-evident, our leadership is extraordinarily privileged. And I think that, you know, I mean, we know from neuroscience now that generates a certain kind of myopia. And so, you know, I think that there are some people who are probably not at all vulnerable, or at least minimally so. And I think that there are other people who are like gravely vulnerable, depending upon what their place of work is, how they identify, what research they do. So I am not well positioned to speak to what people are experiencing.
Greg, sorry, go on, Lisa.
Oh, okay. So the point about neutrality, you know, I think that, you know, for me, the burr in my saddle is the position that the American Society of Bioethics and Humanities has taken, which is to not take a stand on policy issues, in an effort, and I appreciate this, but the effort to sort of be a big tent. But I don't need to rehearse the critiques of neutrality that we've gotten from philosophers like Margaret Urban Walker, or even in a piece Angus Dawson wrote a few years ago about Australian bioethics organizations and their response to what was happening around immigration. So, you know, I think at the end of the day, neutrality perpetuates existing relations of power. That is the bottom line. And I think that there are some positions that are just not defensible. For example, you know, violating patients' privacy, putting people in conditions that are trauma-inducing or life-threatening. Like these things, I don't think that there is any legitimate disagreement about. So that's part of what I'm calling for, is revisiting this conversation within the major organizations. IAB is a little bit different. The International Association of Bioethics, they don't take positions, but they say within their constitution that there may be, the organization to raise awareness of issues of public importance. I've asked 3 past presidents if they can remember any time that that's happened, and they couldn't. That's just a raise awareness call. It's not a take a position call. So the overwhelming silence I attribute partly to the privilege, partly to the fear, and partly to this commitment to neutrality, which I really just think is a false god.
Greg, I'd like to bring you in there, since you're also in this milieu. How do you analyze the risk that people face for speaking out?
So I think Lisa's point is important. It's differentiated. If you are on a green card in the U.S., for instance, or otherwise have a non-citizen status of some sort, we know you can be plucked off the street and sent to El Salvador. That's just the set of things now. But you know, not only bioethicists are privileged, American scientists are privileged, American clinicians are privileged. You know, many of us on this call, no matter where we're from, are privileged. And if there's not a time to expend it, expend a little bit of it, when is that, right? And so I'm not even thinking in terms of the sort of bioethical framework here. I'm thinking about what kind of ancestors do we want to be? What do we want to say after the Trump administration is over, what we did? I see things getting, frankly, worse before they get better in the US, with ramifications for around the world, no matter what kind of future we want to build together afterwards. We need to ask ourselves, what kind of ancestors do we want to be? What do we want to say to our children and our grandchildren about what we did? And the idea that major bioethical societies are saying we're going to remain neutral. This is, I don't get it. It seems so untenable to me that people who are talking about ethics are saying we're going to be neutral in the face of clearly, desperately, abjectly unethical behavior and policies that are coming out of the Trump administration. It doesn't work. It doesn't work for me at all.
Sridhar, you want to chime there?
Yeah, I think this comes from my own background and the way that I've gone through various crises, is that trying to change the gold standard organizations or the big name organizations is really not where it's at. It's really about smaller groups that create new ways of thinking and organizing and acting. Those are where the new ideas comes from. Those are the ways of new methods and new pathways. I think there's some people that can actually change big organizations and their mandates and their stuff, but that takes a long time, and usually it takes a long sort of amount of effort and different kinds of skills and stuff. So if you can change a big organization's mandate or position or policy, then go for it. But I think for most people, what needs to happen is to find a bunch of other people that can sit together and to think about what new ways of thinking and new ways of organizing and new ways of acting is needed to not only deal with the current life-threatening, freedom-threatening situation, but to build a better world that we want to get to on the other side. It's that small groups and the collective action that's actually going to have significant difference, rather than saying, you know, why does Goldman Sachs not take a position on what's going on, right? So I think that that's my perspective on it, but I've stopped working trying to change big organizations. I'm much more interested in changing sort of ideas and norms around that thing. Thanks.
But I think this raises a really interesting question, and I guess it's back to my earlier question to Lisa about the theory of change as to how one overcomes the collective action problem in this moment of crisis. Like, is it a situation where those of us who are affiliated with institutions should be working within them to get them to adopt a more ethical stance with respect to what's happening, or should you simply exercise your right to create external structures that are grounded on more ethical principles and work outside the system? And I mean, maybe you can, people with different resources can work on both those levers. And again, maybe it's not a zero-sum game here, that this is going to require lots of flexibility and lots of nuance in terms of sort of how we'll be able to, or how those of us in the US and beyond will be able to bring about the necessary change. I'm conscious that we've gone quite far past the hour. I am curious, I guess there's quite a lot of specific questions coming through from the audience, so I'm going to try and draw out some common themes. I mean, I think there is this sort of question about how does one individually respond to the pressure of self-censorship? I mean, I think there's also the reality being that, you know, people whose roles are kind of dependent on some degree of cooperation or even collaboration with the government might need to tread a very difficult ethical line of, on the one hand, speaking out in the ways you've described, Lisa, but on the other hand, needing to, you know, accommodate power to some extent. So how is it that, I'd be curious, I don't know if the panel has any examples to share or any principles that could guide an individual's actions in terms of how they should orient themselves based on sort of specific pressures that they might experience as scholars, scientists, and practitioners.
Can I respond to that quickly? I'll start talking and then people can think while I talk. Is that, you know, I think that as ethicists, we're in the business of telling other people what the right thing to do is. We're not into sort of telling people oh, here's what you might think about is the right thing to do. I mean, like it's not about sort of self-development, right? We actually want people to act in a particular kind of way. We're used to sort of providing guidance for people to do the thing that we think is the right thing to do, etc. But within that, I recognize that not everyone is capable of doing everything, right? So we have to measure people's kind of what is the right thing for them to do based on what I use the word capability, right? You can't ask a child to save an adult human being that's drowning in the river, but you can sort of think about an adult and saying there's someone drowning, think about doing something about that. So I think capability, I think the word differentiated is another word that we've been using about, is that, some people like Soji can go to an IMF meeting and a World Bank meeting and has a power and legitimacy and credibility to kind of change an institutional sort of setup. Some of us can teach in the classroom. Some of us sit on the board of Brochet and some, so there's different capabilities that we have. And I would say we all need to spend some time reflecting on the breadth of our capacity or capability to do things and then stretch, right? And then actually stretch that capability rather than sort of saying, oh, I'm just going to do a little bit. It's like, stretch the capability. The second thing is that I am old enough now to understand that people do cost benefit analysis with everything that they do. And some people just don't want to pay any costs. A lot of bioethicists just want to do bioethics that doesn't have any cost to it. Other bioethicists actually do say things that has cost to them professionally and sort of other kinds of ways. And we can't expect everyone to sort of pay a lot of burden, right? Activists are used to paying costs. They're used to being called troublemakers. They're used to losing jobs. They're used to being discriminated against because they're convinced that they're going to sort of on the right track and they're convinced about that. Not everyone is that. I think this is the kind of period of reflection in which people actually really need to assess, am I going to try to win this game here? Or is this about doing the right thing and understanding that there will be costs associated with it, and I'm willing to pay those in order to sort of do the right action? Thanks.
I would just tag on to that. I couldn't agree more with what Sridhar said. At the risk of, invoking the name of Heather Cox Richardson, who I spend a lot of thought too much time listening to these days. If you don't know, she's an American historian who makes sense of what's happening in the world. And she just gave the lecture in the Old North Church on the 250th anniversary of the night of Paul Revere's ride. And it was a really similar story that she told about what happened that night. It was like, well, this one guy's an engraver, and he's really good at going around and making posters about the tyranny afoot and, putting them around the town. Other people know, maps of Boston. Other people know how to get up inside the church steeple. So we all have, depending upon how we're situated, different experiences, kinds of expertise. And to invoke Iris Marion Young here, privilege and powers. And we should all be deploying those to the greatest of our ability. But again, I really want to underscore, not just as individuals. We need to be finding who our collaborators are, as Sridhar said. Maybe that's forming new groups, new institutions, but working together. And yes, write your op-eds, and yes, write your articles, and teach, and do all of the things that you do as an individual. Lend your expertise, but at the same time, if we don't band together and pool that expertise and pool that knowledge, I think we're unlikely to be effective.
So,
Thank you oh, sorry, go on, Greg.
In hearing all this conversation, I also want to raise the issue of complicity. And so you can realize where you can fit in, but Soji is saying many of us have been complicit in sort of the maintenance of sort of the status quo in global health, and we have to sort of reflect upon ourselves about in this moment, how we contributed to it, and how can we be part of building a bigger future and a better future. And some of it may be to shut up and stand back. But in the case of people who are working in the American sphere, in the US sphere, and who are in countries that could be useful allies, you have to think about when silence becomes tactical because you're at risk yourself, or when it becomes complicit because you have power that you could exercise, but you won't because you feel like it comes at too high a cost for you.
And carrying on with business as usual, I think, is an example of complicity.
Soji.
One quick interjection. In my view, I'm going to quote someone else said, in matters of great importance, a person who tries to wash his or her hands in a bucket of neutrality ends up in a situation in which it does not make the hands clean, but it makes the water dirty. So I think it's up to each person to decide how to act or react in these circumstances. And having said that, my own take is the following. What is each person's North Star? Why are you engaged in this field in any case? What is it that drove you? What is it that gets you out of bed in the morning? And then think of it in terms of concentric circles, where the innermost circle is, what are the things that you directly control or that's directly within your purview, and then pour a lot of your brain space and energy into that. The next circle, in my understanding, consists of those things you can influence. You don't control them, but you can influence them, and you can influence the tone, direction of travel there. That also deserves the attention of one's mental space and energy. Then the outermost circle are the things that are neither within your control, nor among those things that you can influence, et cetera, et cetera. In my mind, those are the things about which one needs to maintain situation awareness and relate to others who might be in a position in which it's in their own circle 1 or circle 2. That would be my own interim construct of how to be useful to humanity in this context. Back to you.
Soji, thank you. I think that's a wonderful note on which to bring the conversation to a close. Just in terms of giving us a lens on this question of sort of, how is one meant to act? I think I'll just conclude this by asking each of the panelists a final question, which is, could each of you share something, if anything, that gives you reasons for hope in this moment?
I feel a lot of hope when I see all of the people rolling out into the streets every weekend, everywhere around the world. I mean, if you're asking that broad of a question, what gives me hope within my field of bioethics? The next generation. But yeah, the next generation. But mostly people willing to protest en masse.
I'll go very quickly. I think I'm very excited. I mean, I've been saying this for years now, is that there's a huge transformation happening in the world where people are suddenly writing their own histories that were written by somebody else. There are people who are, sort of creating new concepts in ethics, in philosophy, etc. There's huge potential in the future about other non-European, non-American countries and thinkers and ideas and movements and aesthetics that are going on. So I'm very excited about all of that sort of is opening and emerging. And I'm also excited about sort of, everybody now understands we're globally interdependent. We are not different races living behind walls. We are profoundly vulnerable and interdependent together, and we need to figure out a solution. So I'm very curious and hopeful that we are going to understand that sort of status and then to be able to start thinking about all of us together in that way.
Thank you. Gregg and Soji, do you have any concluding remarks?
So a couple of things. One is I think I'm excited about this idea of a global health and a domestic public health reset in the United States. I don't think like global health or American public health or anything to sort of make deep investments in for a long-term future. So I think that's giving me hope that people are thinking about new visions. The other thing is people have come out of the woodworks, not just to protest on the street, but I sent out a note right after the election saying, we got to figure out how to fight back together. And 3,000 people within 6 weeks came together from all walks of life, a lot of academics, but from all walks of life to do their bit. And I think that's just the tip of the iceberg. And I think it's not just in the US. My friends from South Africa, where I used to work and live, are organizing themselves on what's happening in terms of the PEPFAR and the USAID cuts. I think there's a rising up, which Lisa has hinted on, that is going to shock the world at some point very soon.
Thank you, Gregg. Soji.
I'm very optimistic for several reasons. I'll cite just two. In my conversations with a number of folks in different countries, in different positions of responsibility, I sense an awakening that, we need to take our own destinies into our own hands, such that our health services and its financing are not subject to the whims and caprices of any actor 4,000 miles away. I think that's huge. Now, how well is that going to turn out? How soon is it going to materialize? I don't know. But I think that direction of travel and that shift in narrative is a reason for hope. Another thing that gives me hope, and each time I encounter them, I feel as if I've just had a blood transfusion that's energizing. My students, they're incredibly bright, incredibly motivated, and they're very driven. And I think their generation is just a better generation than ours. So those two, among others, give me a lot of hope. I'm very optimistic about all this, frankly. Back to you.
Thank you so much. Well, look, I'll conclude there. I think it's nice to end on a positive note. I think this has been an incredibly illuminating discussion. Many insights have emerged. I think one that really lands for me, I think, is the necessity of thinking in this moment, both in terms of immediate action, but also using it as an opportunity for a systemic rethink. And I think there is this dual challenge of, on the one hand, addressing the urgent humanitarian needs that the paradigm shift in US policy has brought about, but also undertaking that deeper work of reimagining more just global health systems. As we've discussed, the risks attendant on speaking out and resisting in the different forms are really differentiated for different people. But I think Gregg's question should resonate for all of us, which is the question of what kind of ancestors we want to be, and using that as a sort of framework, along with Soji's excellent metaphor of the kind of concentric circles. So I'd really like to thank all of the panelists and all of the participants today for the courage and wisdom that they've brought to the conversation, and to all of you for being here to engage with these essential and difficult questions. So thank you, everyone, and thanks to the Brochet Foundation for being our host.
Thanks, Sally. Fantastic job. Thank you.
Thanks, everyone.
Everybody.
Bye. Thank you all.
Bye-bye.
Bye.